Oh, I can't see your answers in the chat, or you're still reading.
Sir, I don't know how to send the chat from this thing.
Or you're using your phone.
We're using a laptop.
Oh, okay. There's a chat up there. Conversation or something. After participants, the next thing is conversation. And then you have some icons to indicate your hand up, clapping, and the rest. Can you see those icons?
I can see the hand up and participants, but then I'm not seeing the message part, the conversation part. I don't know if it's just me.
Probably just. Oh yes, I've seen somebody answering. So maybe. All right. So keep your answers coming. So for each of them, somatization is the expression of psychological pain through physical symptoms. You indicate whether it's true or false. And then B, you indicate whether it's true or false. Okay, keep the answers coming quickly. It's also a way of finding attendance. So because I have quite a number of responses. Ima, Aram, Norman. Somebody said they just found it. So keep searching so we don't get the lecture delayed. Okay. All right. So somatic symptom disorder. In psychiatry, as you would have realized, we adopt a biopsychosocial model in evaluating our patients as well as managing our patients. So as opposed to what you have in clinical medicine, where there's an offending agent that is dealt with, we look at our presentation as a midpoint between biology, psychology, and then the social circumstances of patients or individuals before we arrive at diagnosis. So we have a criteria, okay, that spells out exactly what the patient needs to be presenting with before we go ahead and make a diagnosis of any of the diagnoses in psychiatry. Okay. So usually I appoint like 2 or 3 people who respond if I say, do you understand? So I don't feel left alone. So I would appoint the lady who was struggling to get a chat. What's your name?
Sechipia.
You are Sichibia. Okay.
Yes.
So Sichibia and Marilyn. Marilyn, are you there?
Yes, please.
Okay. All right. So if I ask any question at all, I'm expecting you to respond on behalf of the class. Halfway through the lecture, I may switch. All right. So the first criteria is that this individual experiences one or more somatic symptoms that are distressing or result in significant disruption of daily behavior. Okay. So somatization is basically an expression of psychological pain in bodily symptoms. Okay, so let's say an individual misses a flight, supposed to travel to the US and misses a flight, and it's the first time they are traveling. That event might be a little stressful for them, so they might begin to experience some pain in certain parts of the body. So the concept is that there's a lot of psychological outlay there that the brain cannot handle. So it finds ways and means of dissipating that discomfort. So basically, that's the concept of somatization. Now, there are some individuals who may experience one, others who may have like multi-system manifestation. Somatic symptom disorder is one of these, the ones that experience like multi-system symptoms, as opposed to illness anxiety disorder that we shall be looking at in a tick. The criteria B is that these thoughts and feelings and behaviors related to the somatic symptoms are associated health concern manifest by at least one of the following. So you have a disproportionate and persistent thoughts about the seriousness of one's symptoms, persistent high levels of anxiety about the health or the symptoms that they're experiencing, an excessive amount of time, energy is devoted to the symptoms or health concerns the individual may be having. So as again in psychiatry, we say for a symptom to warrant diagnosis, it should be durable, it should be disturbing, and it should be disabling. So sometimes some of the things that our patient experience are things that ordinary people do, but the focus, amount of time and energy that is spent around the symptoms is what actually makes it a disorder, and the impact it has on the individual's functionality is what we design as a disorder. So that same principles happens here in somatic symptom disorder, where you realize the individual is spending a lot of money, a lot of resources trying to evaluate or elucidate their symptoms. The criteria C is that although any one symptom may not be continuously present, the state of being symptomatic is persistent, typically more than 6 months. Okay, so there's another point which lends support to the fact that the symptoms need to be present and be disabling. Okay, and so we try to put a time frame to it to emphasize the fact that the condition has been persistent and disturbing. Am I audible?
But I don't understand the last statement, please, about
Am I
the
audible?
not being present but being symptomatic.
Can you hear me?
Yes, please.
Yes, please.
Okay, all right. Is
I
somebody
have a
asking a question?
question though. Yes, I was asking about the last statement on the last slide. I don't understand the idea of the symptoms not being present continuously, but then being symptomatic.
Although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent, typically more than 6 months. So you have like a combination of symptoms that the patient might present with. They may not come in the same severity, but at any one point, there's something that they are worried about. So it's not like you always have an avalanche of symptoms that the patient is complaining about. They may come in various dimensions, but at any one point, there's something they are concerned about. Is that clear?
Yes, please.
Yeah. The other thing we also do in psychiatry is that we have specifiers. There are some specifiers that we add to each of the symptoms that we define in psychiatry. So for this one, we want to be sure if the patient is experiencing the symptoms with predominant pain. Previously in ICD and DSM-4 and ICD-10, there was this diagnosis we labeled as somatoform pain disorder. Okay, but now that is subsumed under somatic symptom disorder, and we want to be certain whether this patient has predominant pain or not. And then you also want to specify whether the symptoms are persistent. That is, persistent cause is characterized by severe symptoms marked by impairment or long duration. That's greater than 6 months. You also want to specify the current severity, whether it is mild, it is moderate, or severe, based on the number of symptoms the patient is presenting with. So these are some specifiers you can add. So having made the diagnosis of a somatoform disorder, there are a few specifiers you want to add. And the reason this is critical is because you may want to factor this into the patient management scheme. So if the patient does not really have pain and all they have are like abnormal or rising epigastric sensations from time to time, the kind of management you design will be different from an individual who is severely having pain. Okay, and the medications that you have to give also differs. A few facts and figures about the disorder. The prevalence is like 0.2 to 2 among women and less than 0.2 among men. I'm sure you can figure out why this disparity occurs. There's a lot to do with women and their cycles and estrogen and how it plays out with serotonin. So that tends to affect women more than men, just as you may have in depression and a few other stress-related disorders. The cause, you can have it being chronic, can be fluctuating, but it rarely remits. If I have time, I'll show you a patient that I saw who had this condition. But these are individuals who will be jumping, will be doctor shopping, moving from one doctor to the other, trying to resolve their problem. But it really completely goes away without treatment. Now the onset is usually at adolescence, usually before age 25. Most common among those who are unmarried females, and then from lower economic, socioeconomic groups. And I think this socioeconomic dimension occurs in almost all the psychiatric disorders, where there are individuals who come down with these issues because of the socioeconomic status. Now, how do we get around it? It's important to know that there's no well-established treatment modality. So there is no textbook profile to use in managing these patients. You have to take them case by case. The most important thing is to ensure that you do no harm, as ethical as you must be as a doctor. And by doing no harm, you can actually cause harm by not fully exploring the patient's history. Okay, so if your history is patchy and you do not consider all other factors the individual may be having, we end up doing the patient a disservice, requesting a lot of laboratory investigations and running them dry. So you need to do a comprehensive assessment. The medical history should be up to scratch. You need the medication they are currently on, as that could also influence how the presentation goes. And then you need to do a substance use history, fully explore what substances they are using. And then you look at the psychiatric comorbidities. Okay, if there are any depression or psychotic disorders in the background, you need to be able to explore those ones. And then find out about stress. We've mentioned that stress is a trigger to most psychiatric illnesses. So explore what their day-to-day activity is at work, at home, how their marriage is going, how their relationship with individuals are running. And then you'll be able to rule out a lot of possible medical conditions that might, or psychological conditions that might be underlying. So obviously, by taking an comprehensive history, you will know that this is a diagnosis of exclusion. Okay, so you don't see a patient for the first time and then make a diagnosis of somatic symptom disorder. You might mistreat the individual, or you do the individual a big disservice. In the long term, you may want to support the individual by using supportive psychotherapy. Okay, so we establish an empathic relationship with the individual. We walk through their various modalities of thinking, and then try to support them as much as you can. There might be a temptation to see them as frequently, because sometimes when they are presenting their symptom, they make it look so severe and so urgent that you might be forced to see them frequently. But the way to do that is to space them out. In terms of investigations, you try and explain to them that it might not yield any results. The reason I'm saying this is that for some of the patients, after you've made this diagnosis, in fact, before you even made the diagnosis, it would have come with a barrage of investigations, and they keep asking you whether there is any other thing they can do. And they'll go online and read about the latest investigations. So as a doctor with your experience, you need to let them understand that doing those further investigations might not really help. You need to just let them understand that there's some psychological distress that is manifesting as somatic symptom. Because it's a diagnosis of exclusion, we always advise that when a patient is being referred, let's say to a psychiatrist or to a psychologist, the gatekeeper physician protocol is observed, as in the highest individual in that institution should be the individual to refer. So by the time it's getting to the psychiatrist or the psychologist, a lot of ruling out and has been done, and it makes the progress of the therapy goes more smoothly than having the therapist evaluate the patient from scratch. The next somatoform disorder is illness anxiety disorder. So as the name suggests, there's an illness and there's an anxiety associated. Can you hear me?
Yes, please, we can.
Yes, please.
Okay, all right. So in this condition, the criteria A is that the individual is preoccupied with having or acquiring a serious illness. Somatic symptoms are not present. Can you see the slides?
Yes, please.
Where did we get to? What was your last slide, you remember?
I think we have to go back so that. No. Yeah, no, the one before. Not this. Yes, I think we finished talking about this. They were talking about the treatment. Yeah, the gatekeeper. Then you're going to the next one. Then I think you went off.
Sir,
Yes.
you started with the illness anxiety disorder.
This one.
Yes, please.
Whew. Okay, no problems. Yeah, so it means I exhausted this slide.
No, please.
Did I?
Please.
Okay,
You
so
hadn't
illness
started.
anxiety disorder criteria A is that the individuals are preoccupied with having or acquiring a serious illness. Okay. The somatic symptoms are not present, and if present, they are only mild intensity. If another medical condition is present, there is a high risk of developing a medical condition. Strong family history. The preoccupation is clearly excessive. So for these patients, they are really concerned. And I cited an example of a patient who has a scar and then start thinking that this scar may degenerate into an ulcer, and then the ulcer will become huge, uncontrollable. Maybe after they've seen somebody who has a big ulcer that is not healing, and they just keep on thinking about what could possibly happen, to them. and that obviously degenerates into a lot of anxiety, okay, about the health, and they are not able to focus and all that. And these individuals will do a lot of checks on themselves. But at the same time, I was saying that they avoid seeing doctors or going to hospitals. And the reason is that they anticipate that the doctor may slap a deadly diagnosis on them. So they don't want to compound their anxiety by seeing a doctor. But at the same time, they keep evaluating and examining themselves for signs of a complicated illness that is that they're anticipating. Okay. Now, I mentioned that these symptoms would have to persist for like 6 months and beyond, and that is to distinguish it from individuals who experience this and within um, decent limits of normality. Okay, so if you give them 6 months and they have this level of persistence, then you know there's a problem. And obviously, in psychiatry, the illness should be distinct and not be explained by any of the bigger mental health disorders that we know about. There are some individuals who may seek care, others will not seek care, and it must be obvious in your evaluation so you know how to manage the patients. And we manage these individuals primarily by evaluating the way they are perceiving themselves and the illness. You do cognitive assessments and then look at the cognitive distortions and perceptions that they have about the illness and deal with them. They could be having what we call maximization, where they blow things out of proportion. So you help them to identify it and use your psychological skills to unnerve them. And then you should have some stress management as part of your protocol, because these individuals have excessive amount of anxiety. So you need to be able to relax them. You need to tell them to take a walk. You need to, do the things that they like doing and try to ignore the symptoms. Not ignore, but try to lower the blow that it gives them when they experience them. And so there should be also some explanatory therapy where you educate them about the signs and symptoms that they're experiencing, especially for those where they have some pre-existing medical condition that they think might blow out of proportion. You just explain to them what is not possible within the realms of clinical medicine. Can you hear me?
Yes, please.
Yes,
Yes,
please.
sir.
Okay, all right. The next one is conversion disorder. Conversion disorder is the old name, and the new name is now functional neurological disorder. The DSM-5 was launched in May 2013. So the old folks, those who were used to conversion disorder, are still using it, and you may come across that in a lot of your readings. Okay, but the new name that's acceptable now is functional neurological disorder. You probably will see one in the next slide. So these are individuals who have altered voluntary, motor, or sensory function. Okay, and the clinical findings provide evidence of incompatibility between the symptoms and the recognized neurological or medical condition. So the symptoms are there, but it doesn't really fit any neurological classification. The symptoms are not explained by other mental disorders, and it causes some grade of occupational and social dysfunction. You need to specify whether the patient presented with weakness, paralysis, abnormal movement, swallowing difficulties, speech difficulties, whether they are having a seizure attack, they are having anesthesia or paresthesia in certain parts of the body, or they have special sensory symptom. And I was saying unknowingly to myself, not knowing that you were listening to me, that I had a patient who had a visual components. Okay, so he was also referred to me by a neurologist, and his issues were huge. He was so concerned about his inability to see. He's been cleared by the ophthalmologist. In fact, the wife thinks that he can see, but he keeps saying he cannot see. Meanwhile, he's able to drive. He says his vision is deteriorating. He's been out of the country on account of that symptom. So if a patient has all these neurological, symptoms, and there's no identifiable cause as per specialist review, then we think the individual has a functional neurological disorder. You can also specify there whether there's an acute or whether there's a persistent one. I made an example of a patient who lost the father. She saw the father deteriorate from CA, and then he eventually passed on. She was at the scene. She actually saw the father passing. And subsequent to that, she couldn't talk. She did not eat. She could not eat. She does not respond to anything. And the neurologist saw and they referred to us. And for her, eventually we had to stimulate her brain before we got her, out of that state. So the manifestation was neurological, and there was a clear psychological stressor. For some of the patients that you see, the psychological stressor will not be obvious. Okay, it's either the patient is mute at the time you are seeing, or the stressor is not obvious to the patient for them to even articulate for you to see that, oh, there's a problem of that nature. So you want to specify it. Easier when the stressor is obvious because of the treatment modality that you will deploy. It's commoner in rural areas, lower socioeconomic status, less medically intense individuals. It's more common in men than women. You need to assess the patient if he has not been, even if he has been assessed by the neurologist, you take the opportunity to assess yourself as an individual, as a doctor, assess their level of knowledge, listen to how they are presenting. They might be, whether it's dramatic, histrionic, or labels indifference. Labels indifference is an individual who is unconcerned about a medically significant sign or symptom. Okay, so a patient who has paralysis in the left arm, if it were really organic, you see the patient really concerned, but you don't see that to patients who have functional neurological disorders. Yeah, so there are some psychoanalytic theory that underlines it, that a patient might be experiencing some traumatic event which produces anxiety and psychological conflicts. And the anxiety and unconscious psychological conflicts are converted to these somatic symptoms, and these symptoms provide the individual some primary gain, that's a relief of anxiety, and they may also eventually provide some secondary gain for that individual. The sympathies, having to go to the hospital and everybody's around you. For some of the individuals, this might happen. The treatment considerations are to identify what the stresses are, especially for the individuals who have specifiers as obvious psychotrauma. Okay, so use that as a point of managing the individual. You do an insight orientation therapy, do rehabilitation where possible. You space out their consultations as widely as you can. And for some of the patients, there might be the need for you to introduce some SSRIs or even some anticonvulsants for the severe types. There are various shades of presentation. For the severe types, you may even have to stimulate these individuals. Okay. So you read about this. I'll give you the slides and you read about this. It's time. Now, factitious disorder are individuals who falsify these symptoms. Okay, these are not people who spontaneously experience signs and symptoms, but they actually falsify it. So they either falsify it on themselves, which is factitious disorder by impose on self, or they falsify that on somebody else, which we call the factitious disorder imposed on another individual. Okay. The old name for this is Munchausen's syndrome or disorder, where a patient will let's say smear something red on the individual to indicate that the child is bleeding, you know, to get an excuse duty or to evade going to work or something. So if it's persistent, well over 6 months, and it's recurrent, we'll manage appropriately. There are some other conditions which do not meet criteria for the above, either because of the duration, not the duration criteria not being met, or the cluster of symptoms expected also not being met. Okay, so you can take the post-test and then I'll let you, but you have another lecture after this, don't you?
Yes, we
Hello?
do.
Yes, please, we do.
Hello?
Hi.
You lost me again?
No, we do have another class now.
Yeah, I know you have another class now, but did you lose me at any point?
No.
Okay, all right. So you can leave the answers in there. Or you can see. Yeah, I think it's sharing now. You can leave the answers in there and have a good time. If you have any question, you can reach me privately. I'm sorry for all these mishaps. I usually prefer Zoom, not Teams. Okay, those of you can answer should before I turn off. God's glory. Glory.